About us. For those of you who know us, you will have known us as a software company. We deliver lots of software across the NHS. We've got about 60 clients now. I know this is 50. I just haven't had the opportunity to update it. And we have very good retention rate, but that has largely been around supplying software, medical revalidation, job planning, e-leave, e-rostering, and various other workforce-based systems. We've been around since 2012. So as I say, for those of you who know us, that's how you'll know us. For those of you that don't, that's one of the aspects of the things that we do. And the reason why actually we're here talking about the future of workforce planning is because we as a company are starting to transition. And we're starting to transition towards this thing called workforce optimization. And it became very clear when we started to look at this that systems may not be enough. So actually we're thinking more about how do we support and accelerate trusts or services within trusts to the point where actually they can deal with workforce planning and workforce optimization in a way that doesn't provide too much of a burden on the trust. Can we do some of the heavy lifting? And some of the areas that we're looking at are around things like job planning, performance review, training, team job planning, which Brian and I will discuss as we go through, service design strategies, gap analysis reporting, optimal job plan templates, the systems itself, largely around how do we utilize the data that you've got to provide you with really clear outputs on how to get to where you need to be. That, for me, is the end of what we at SARD do. If there's anything you wish to know more about, as I say, right at the very end of the session, please let me know. I'm happy to talk more about it, but equally, we're happy to engage with anyone that has any sort of further questions or wishes to see how we're delivering this. But the primary focus of this session is not about what we do. It's about sort of the wider state of workforce planning within the NHS. So without further ado, I would like to introduce everyone who doesn't already know him to Brian, and invite Brian to sort of briefly give an introduction to who he is, what his experience is, and why it's a useful time for us to talk about workforce planning. So Brian, if you're there.
I'm here. Yeah.
Excellent.
Hi.
Would you like to introduce yourself, Brian?
Yeah, I'm Brian Jones. I'm the director of a company called Medical Workforce Solutions. I'm also the sort of medical team job planning lead at SARD. I've been working with the NHS for 32 years now. I think it'll be in August. Started off my journey at the Northwest Regional Health Authority in 1992, recruiting registrars and senior registrars as they were known then, and then became a medical staffing manager at Manchester Royal Infirmary, predominantly looking after junior doctors, so junior doctors' hours, recruitment, locums, onboarding, those sorts of things. I did that for about 12 years. Then I started to work in the mental health sort of environment in the Northwest, looking at hospital at night, multidisciplinary team working out of hours, and trying to establish whether we could, reduce the need for junior doctors in training in psychiatry. Did that across the whole of Greater Manchester, did some huge audit on the work that was being done on the ground, and we developed new sort of workforce models across those trusts. At the end of that 2-year project, it was funded by the SHA. I then went it alone really and set up my company. And over the course of the last, when did I set the company up? 2007, I think. So yeah, a good 15, 16 years. I've worked with over 30 organisations, mainly in the medical HR sphere. Done lots of operational stuff, managed teams operationally. But certainly over the last 10 years, I've really been focusing on job planning and workforce planning. So helping trusts to get their job plans into the right shape, making sure there's sort of the disciplines in place to do it annually and do it effectively. And over the last 3 or 4 years, started to think about team job planning. So not just focusing on the job plans themselves, the capacity, but looking at, what do services need from the senior clinical workforce to deliver the work. How many do we need? What do they need to be doing? I developed a workbook in Excel that I would work with individual clinical teams with, and then clearly had a conversation with SARD about a year ago about this, and we've developed a sort of a web-based team job planning system, which links in with your job planning system and enables you to carry out some sort of capacity and demand analysis. I think over the last 4 or 5 years as well, there's a couple of other things I've been doing. I was an associate with 4 Eyes Insight, for those that are familiar with them. They're a sort of a medical productivity company that really, in the main, look at in-session productivity for theatres, outpatients, diagnostics. And I was the job planning lead with that organisation, worked with probably over 15 trusts for the programmes of work that they were delivering. More recently, I was the rostering manager, medical HR lead at the Nightingale Hospital in the Northwest. So I have had some input into the workings of other staff groups. I've done some AHP job planning in the past, and clearly, was rostering practitioners across all disciplines when I was based at the Nightingale in Manchester. So that's me. Hopefully not too long, but yeah, that's my experience to date.
Thanks, Brian. So essentially, moving on, I'm essentially going to sort of interview Brian, but conversationally, and we've got some questions that come up, and we hope they're really pertinent to people in terms of the current conditions of the NHS and what's working and what's not, with all revolving and focusing around workforce planning. So thank you, Brian, for that. This is my first time as an interviewer, so be kind. No. Yeah, we did set up some sort of questions to begin with, but maybe along the way we sort of probe a little bit deeper. And if there's anything that we talk about during this session that those that are here as part of the webinar wish to explore a bit further, then please make a note. And then in the audience sort of questions, please feel free to come back to Brian with any sort of further questions that you may have. So I think the best place to start, Brian, is to think about, or from your experience, what are the main challenges currently facing the NHS workforce at the moment?
Yeah, well, I think a lot of this is well documented in the press at the moment, but I suppose from my perspective, I think first and foremost, despite advances in medical practice, new treatments and technologies, drug advancements, demand is up and it's rising. And I think, that primary care and social care cannot meet the demand, and this filters into our hospital settings. I think many staff are burnt out. They're leaving the service earlier than we would wish, and we're not attracting new staff at the same rate. I think the estimate at the moment is that currently across the NHS, we've got a 7% vacancy rate, which is huge, and it's growing. I work in medical staffing mainly, but and I can see now that even junior doctors are opting out of substantive training roles. They're working as bank or agency doctors. Some of them are looking to work abroad. I think this is affecting the number of candidates that we're potentially getting for consultant posts. Consultants are retiring earlier due to burnout, or the pensions issue, which has been well documented. And I think all of these things are a byproduct of poor workforce planning.
Okay, I mean, and of these challenges, because you talked about the fact that you've obviously been involved in the NHS your career for sort of some 32 years, have these sort of challenges changed and evolved over the course of your career? Have you sort of seen these things exacerbate or get worse or get better?
Yeah, I don't do operational medical HR anymore. But you know, when I started at the MRI in Manchester, 30 years ago, almost, you know, we filled all of our junior doctor posts. We didn't have any vacancies. You know, I was at a major teaching trust. I'd be looking for possibly 2 to 3 locums a day. There were 4 medical locum agencies in the UK. There are now over 40, I think, on the framework. Junior doctors tended to work their way through the grades. You know, they didn't take career gaps. Consultants worked till 65. I think now, because workforce supply is so low, that agency doctors can name the rate of pay. Yeah. Lots of trusts that I've come across are spending, you know, circa £5 to £7 million a year on medical bank and agency, you know, which in real terms is, I don't know, it's the equivalent of about 40 to 55 substantive consultants, I think. Yeah. So there's some of the things that I've really seen over the last 30 years in terms of sort of at least the medical workforce.
Yeah, I mean, I've started writing an article about the sort of future trends, and actually statistically it bears out that we talked about contingency spend some sort of 3 or 4 years ago being around 4.7 billion annually, whereas a year ago that had increased to 6.1 billion. And obviously there's some concerns around that, because in 2024 and 2025 there's the introduction of the agency spending cap, which is currently obviously lower than last year's spend, but for many people involved feel that that's sort of unachievable. So it seems those trends will continue.
Yeah. Can I just add to that, because I think it's noble to try and reduce the spend on contingent workforce, but you've got to backfill that with substantive workforce. Yeah. The work isn't going away, it isn't reducing, so you need to have a plan for what you're going to do around your substantive workforce to cover off that gap.
And I think certainly we were at the Confed Expo last week, and certainly a lot of the chatter, and actually some of the presentations are around that, you know, for really the first time in forever almost, the amount of recruitment was less than the number of people leaving. So normally you would maybe sort of keep the wheel spinning, and there were struggles. So they had to think of new ways in which to deal with this sort of getting substantive posts in. So that's the challenges, which I think most people on this call are probably acutely aware of in their own settings, of what those challenges are and what they mean broadly. Can we talk about what the barriers are sort of specifically to effective workforce planning as a process?
Yeah, I think the first point I would make is that just the discipline of workforce planning, or the function, I don't think it's resourced adequately in trusts. Certainly in the trusts that I've worked with, you know, there are some really good workforce planners about, but lots of organisations haven't got the people to deliver it. And dare I say, I think some organisations haven't got the commitment to do it and do it well. I think one of the other sort of barriers is around data. You know, I think you can only really effectively workforce plan if you've got strong data sets to understand the demand on services. It's getting better, but it needs further improvement, I think.
So there's some almost level of irony about the fact that there isn't the capacity to meet the demand to undertake demand and capacity process that is required in order to workforce plan properly.
Yeah.
Which is so on that, I mean, you sort of touched on some of the trusts. Are there any sort of clear mistakes that on your travels that you feel that trusts are currently making about the workforce planning process? And I don't want this to feel like it's a negative, the trusts are doing things wrong, but just sort of things that maybe trusts that sort of processes they're not undertaking, which actually, if they did or didn't, would sort of successfully impact how they workforce plan. So are there any things that are sort of any mistakes that you witnessed that you would like to help change if you could?
Yeah, I mean, if I was just to focus on medical job planning or medical workforce planning, I think almost every single organisation in the UK at the moment is doing capacity planning. So individual job planning, understanding what each individual is sort of committing to for the forthcoming year, but they're not doing it very well. So they're doing the capacity piece, certainly, or they're attempting to do the capacity piece. And I think the culture in many trusts in relation to this is just in the wrong place. It's not being done effectively. The outputs from that process, so a detailed capacity plan, are not being collated and shared with the doctors who've gone through the process. I think, you know, as a result, most trusts are achieving less than 50% compliance.
Yeah.
On annual job plan delivery. They then end up closing the round off, and then they start again, and they're just chasing their tail, really. And I consider it to be a meaningless exercise for all participants. We've been at it since 2003, which is 20 years, and really we've not really made any great progress. You know, lots of trusts have got systems now to support this, but I'm going into organisations and trying to sort of remediate, really, and reboot the process, because they're not using the system. Some have reverted back to paper, in my experience. Yeah. You know, there's all sorts of things going on, and there's a big question mark for me about whether, you know, if we don't do this properly, my advice would be to actually stop what you're doing. There's no point carrying on chasing your tail in this you know, in this process.
Yeah, we get a lot of feedback around it being an administrative task as opposed to a solid process that actually leads to impactful sort of outcomes in terms of reductions of backlogs and ensuring that referrals are met and so on and so forth. And I know our medical director, Professor Joe McDonald, who I think is probably on this call from Turkey, he describes it as a meaningless paper chase. So it is about essentially moving away from that. So that, I don't want, as I said, I don't want this all sounds so negative, but I think it's important, as we discussed earlier, Brian, you can't sort of sugarcoat some of these things. These are challenges that need to be faced. There are barriers in the way. There are things that trusts do, maybe without really knowing that don't have the positive impact. So let's turn it around a little bit and think about what the fundamental building blocks for good workforce planning are, and you know, what should trusts and colleagues be actually focused on? What's gonna move the needle that hasn't moved in nearly 20 years?
Yeah, well, it goes without saying, but it's all about patience. Patience drive demand, you know, workforce demands. I think we need to start to really, the sort of the building block is to focus on how many patients we've got that are being referred into services. We need to determine how much time they interact with the service, either in a clinic, in a diagnostic session, or indeed in an operating theatre. We need to understand the trends in referral rates and what that means for, one, the sort of current human resource requirement and the future requirements. Yes. I think workforce planning has to be patient-centric. You know, I think if you think about it really simply, you know, if you've got a patient that's going into a, I don't know, urology team, they may go into a urology clinic initially, and they need to be seen, and there's an admin that follows on from that. They may be signposted to a fast track clinic, so like a prostate clinic. They could be diagnosed. It could be diagnosed at the same time, so the diagnosis could happen on the same day. All of these things take time. They need to be written up. There are different people contributing to the delivery of that piece of work. They then may ultimately end up in a book for an operation. They need a pre-op assessment, attendance at a clinic. They need to attend the the theatre itself, have the operation, possibly recuperate in a bed for X number of days, and then be discharged, and then come back into a follow-up clinic. So for me, it's a numbers game. All of these things take hours and minutes, and I think if you start from that basis, start from the patient, and then the journey, it'll give you a fighting chance of understanding what you need across your workforce.
Yeah, I mean, it seems obvious to say in a way that it should be patient-centric, because that's what the NHS exists for. And it also seems obvious that utilising data should be your starting point when you're thinking about planning. You know, when you're thinking about how do you plan for this, there needs to be a basis that sits underneath it, that in order to actually plan. And you mentioned before about sort of almost the individual nature of job planning at the moment, and how you may be best served not doing it at all if you're not linking it to those things. So obviously patient-centric is very important, but there's also external factors that we've discussed before, which is around the levels of attainment, for both job planning and for e-rostering, but with regards to sort of job planning at the moment. And I think you gave a great talk at NAMPS back in the winter of last year, where it talked again about the fact that over the sort of past 20 years the needle hadn't moved, and that actually if you look at levels of attainment, there are only a very small handful of trusts that would sort of self-declare that they were at levels 3 and 4, but that is the goal. So do you think it's achievable for trusts to get to level 4? How can they do it? Should they? Why should they do it?
Yeah, I mean, absolutely, it's achievable. I mean, I think when I last looked at the data set from NHS England Improvement, I think there was, 2 or 3 at level 4. I've not worked with those organisations, so I couldn't say for definite whether they were actually there. I think there were about 7 or 8 at level 3, one of whom I have worked with, and I was surprised to see them on the list, but it is a self-declaration process. But, absolutely, it's achievable. I think it's possible with good data sets to develop for medical job planning, a PA-based demand model for your service that covers off patient-facing activities, MDTs, admin, all of your non-clinical stuff, SBAs, etc. And then you can start to use the individual job planning rounds to compare capacity against the demand model and understand the extent to which, what the size of the gap is really. And if you do it forensically, where is the gap? Because it will be in specific areas of the business. I think first time around when you do this, it's not easy. It takes time. But I think once you've got a demand plan in place, and you really go for it, I think the future annual planning should be a lot easier. But it's really sort of taking that leap, really. But yeah, absolutely, it's achievable. I mean, it's a target. I think given the nature of where we are today around the workforce issues that we've talked about earlier on, I think it's almost non-negotiable. We need to get to grips with this and move it forward.
Yeah. But well, thank you. I mean, you talked a lot, and we've talked a lot about the sort of individual job planning and team job planning, and then capacity and demand, and sort of some ways as interchangeable terms. One of the things that we hear a lot is different definitions of what those things are. But from even trusts themselves. So can you just, what in your opinion is the difference between an individual job plan and a team job plan?
Yeah. It's interesting. I've been working with an organisation recently, and they said they do team job planning, and actually what they do is they get the consultants to meet as a team in a room, and they divide the work up, and determine when people are going to do the work, sort of scheduling. And for me, that's not team job planning. That's just a conversation, really. It's an important conversation. But team job planning for me is about patient demand and the time it takes to complete the work. So it's, I think that those two things are different. I think once the team job plan is drafted, it should be shared with the wider clinical workforce so they understand the size of the ask. And then they may then can have a conversation about, well, how are we going to do this? How are we going to tackle it? How are we going to divide the work up?
Yeah.
Some people think team job planning also is about. I did speak to somebody that presented. I can't think of his name. He'd presented at a conference a couple of years ago. A consultant. It was about the team being committed to delivering the work. That's more culture, really, and the commitment. But yeah, all of these things sort of feed into it, don't they? I think individual job planning should start after you've built your team plan, your demand model. But I mean, I don't like the term individual job planning. I mean, I think this is one of the problems at the moment. Lots of, walking to lots of trusts, and each job plan within a clinical team, they're all signed off in isolation of the others. Sometimes they're signed off at different times of the year, and actually it should be done at the same time. And I'd prefer to call it sort of collective or team job plan review instead of individual job planning. I think, there's 15 orthopedic surgeons all job planning in their own little silo, really, with no understanding of what it means collectively. I think if doctors will understand the purpose of individual or collective job plan review, and why it's important, how it influences workforce planning if you actually start with the demand model first.
Yeah, it seems to make sense that people don't, certainly in the NHS, they don't often work in isolation, right? It's not how you practice medicine. You may be responsible for that part of someone's care, but it's still part of a group. And so I suppose I understand that actually the whole process is really team job planning. It just then comes down to what's the service's responsibility, and then what are the responsibilities of those different component parts within the service, and how do they pick up the areas that they need to. So thank you for that, as I say, because we get a lot of people talking to us in different ways about what they consider to be team job planning, and I think it's useful to sort of define what team job planning is and how it sort of works for you. So you've obviously been through the process of it before. How do doctors react to sort of team job planning, as opposed to, we've already talked about the individual side of it, but how do they react to team job planning when they first go through your definition of it and come out the other side?
Yeah, I think that, well, they're really skeptical about individual job plan review for the reasons I've already sort of set out. Yeah. So when it comes to team job planning, that sort of skepticism hasn't really gone away. But I think once they see the team plan, and they, doctors work on a sort of evidence-based basis, don't they? Everything has to be evidence-based. And I think if they see team plans that are, based on sound patient and activity data, I think it can act as a catalyst to improving sort of job plan review compliance. I think when they see the team plan, the demand model, and the collective job plan review, and they can see what that means from a sort of capacity versus demand perspective, I think lots of that skepticism dissipates. I think they then begin to realise this is about, it's about workforce planning, it's about patients. It's not about how many PAs I'm going to be paid and what my on-call supplement is going to be. It just opens it up really. It's a much broader conversation.
Yeah. Thank you. Okay, so sort of changing up slightly, if you could essentially give any trust that you work with 3 pieces of advice, three things you could take to a trust to help them improve how they workforce plan, what would those things be and why?
3, okay. I may have more than 3, but let's see.
We'll let you off. As long as it's not 20.
No, it won't be. Yeah. I think the first thing is just stop doing what you're currently doing. You know, unless you're doing this well, really just stop. You need to reboot the whole job planning process. I think medical job planning tends to be managed by medical HR and clinical directors and service directors, but I think, you know, you need to now involve finance, informatics to produce a meaningful demand model. You need to give yourself enough time to deliver it. I think if you do this quick and dirty, and I think this is one of the problems with workforce planning, I think in the NHS, a lot's been done on the back of a cigarette packet. It's very quick and dirty. I don't think that'll cut it going forward. I think job plans themselves, and then actually the overall approach, it needs to be based on reality, not on what your budget or pay envelope is. I don't think you should fudge the numbers. I think if you start to create job plans that are realistic, that, you know, and that recognise the work that the doctors are doing, then I think you're gonna end up in a better place than you currently are. I've worked with lots of trusts where they've told doctors that you just need to shoehorn all of the things that you do into a 10 PA job plan. I think that's the wrong approach. How many am I on? I think I'm on about 3 or 4, maybe. I'll add another one. I think engagement is key. I think you need to get your senior clinicians on board. That's the whole of the consultant workforce. You need to work really closely with them and get them to understand what the benefits of doing this properly are.
Yeah. I mean, I think that just before I move on to the next question, one of the things we hear about, and I think you're right, there's various trusts work in different ways. And I think part of the issue, as we sort of talked about earlier, was the irony that, you know, the sad irony that there just isn't the capacity to undertake this process in order to make things better. So there's some challenges around that. I think some solutions, but just in terms of, so you've given this advice, what is the impact of both good and bad workforce planning, and essentially what is the cost of doing nothing?
Well, if you do it forensically with good engagement, I think organisations will be able to prioritise where new investment will be allocated to expand the clinical workforce. I did an exercise recently when we were testing the SARD team job planning system, where it was clear that one of the teams was just exponentially building up a backlog. There were 4 clinicians short, not all consultants. They could probably get away with a consultant, a clinical fellow, and maybe a couple of clinical nurse specialists. And that would fix the problem. It wouldn't fix the backlog, but it would certainly get them to a position where they could manage sort of business as usual. And then another team, they were pitching in for 1 or 2 additional surgeons, and the outputs of the team job plan and the capacity assessment was that actually they had enough consultants to do the work, really. And probably what they really needed was some in-session productivity to meet the demands on the service. So, you know, in that sort of conversation for director of finance, you know, you've got a plan, you understand capacity, and you can articulate that to the director of finance, and you know, he can say, okay, well, that team there needs the resource. There was one team in that organisation where they had 30 consultants, and, you know, elderly medicine, and 15 of those were employed through agency and costing an absolute fortune. And with the modelling that we did on the team job plan, looking at safe staffing models for frailty, inpatient elderly wards, and the small amount of outpatient work that they do, you know, it demonstrated, and this was based on Royal College guidelines, it demonstrated that it probably could reduce the workforce to 26, which is 4 locum doctors, costing probably about 20k a week across the 4 of them, which is what, about £1 million a year, if I've got my maths right.
It's a big number.
It's a big number, yeah. So, you know, so that money could be vied into the teams that really need to expand their workforce. You know, you don't always need a consultant, you know, which, you know, a specialty doctor or a clinical nurse specialist may do. I think in terms of, for me, well-resourced teams, I think they have less stress and burnout, lower turnover, better patient outcomes, lower waiting times. And if you flip it over, if you don't do this properly and you don't resource effectively, then higher stress, burnout, higher turnover, increased waiting times, poor outcomes, higher contingency spend. I could go on. Yeah. I think if you don't do anything, I think it's all of the above, but probably an increase in complaints, SUIs, maybe even a public inquiry or two. Lots of the public inquiries that have been documented over the last 2 or 3 years, lots of the summaries are about workforce.
Yeah.
And but it's also about poor practice. But I think if you're working in a team that's not properly resourced, I think that changes. I think that fragments the team potentially, and that leads to poor clinical practice. It needs leadership, clear plans, all of those things, to get you into a much better position, really to ensure that. I think for me, it's about better patient outcomes. That's the bottom line with this. So if you do this properly, hopefully patient outcomes will improve.
And that should be the goal, obviously, of everyone. In the NHS, again, going back to that sort of purpose. So we've got a few minutes left on this section, and I know that a lot of what we've talked about may feel it could be relatively negative, but I think actually when we talk, there's a real message of well, actually this challenge can be met. So how do you see the future of planning in the NHS, like particularly with advancements in sort of new technologies, AI being one of them, and changes just in the general healthcare landscape? Is the future bright? I suppose.
Well, setting aside the fact we need to do this and we need to start the journey now, I think, if we haven't already. But there are some opportunities, I think, with the advances in technology, AI, virtual clinics. These things may actually reduce the number of clinicians that we need, or it could free up time for the doctors potentially to focus on the work that absolutely requires their intervention. We were at NHS Confed Expo last week, and I saw a presentation from a company. The name I can't recall, but they've developed an AI generated virtual clinic for patients who've had cataract surgery. So you've had the surgery, you're back at home, and AI calls you up in its beautiful robotic voice and part robotic, asks you to verify who you are, asks you a series of questions, and then asks you some clinical questions that would normally be asked in a face-to-face follow-up clinic, to assess how the surgery's gone. And from the responses that you give, there's the potential for that AI caller to effectively discharge you, or if they feel that there's some complications, to pull you in for a face-to-face follow-up clinic appointment with a consultant. I think if I remember rightly, they'd done this across, I think it was 6 organisations. They'd looked at they'd contacted 9,000 patients, and 6,000 of those were discharged through this process. And I think if I roughly estimate that, that's what, 6,000 patients. Probably the pre-clinic admin, the attendance at the clinic, the post-clinic admin, probably in the round takes probably about an hour of people's time. 6,000 hours. What's that in PAs? About 1,500 PAs per annum per week. 30? That's quite big across 6 services. So there is some opportunities, I think, going forward. But we're not clear how this is going to roll out. But it's inevitable that some of this work or some of these developments are potentially have got they're going to give us the opportunity to either reduce the workforce or to keep it as it is, but to be able to manage the demand in a more effective way.
Yeah, I suppose it's where you point the resource. I know you're talking about. It's a company called Euphonia.
Right.
The DORA system is around the cataracts thing. And
Yeah.
I think that's one of the things you and I discussed previously, was actually there's going to be sort of technological interventions that are actually not directly based on workforce planning, although there are some that will help with that in terms of trend analysis, predictive analysis, being able to quickly roster people, utilizing AI and so on. But it's actually a lot of the indirect stuff, like being able to sort of undertake full clinics, or at least in this case with the cataract service, to reduce that, and that in itself. But that sort of brings me to the point that you can only realize those savings, as it were, or if you understand what your demand model is in the first instance, then you can only react to how those things can free up other resource to be reutilized if you've got some semblance of workforce planning in place in the first place, to be able to say, well, we had X people doing this, we don't need to do that now, so how do we redeploy that resource in a significant sort of manner?
Yeah. I mean, I think I think organisations need to get the workforce plans in order now, to paint the picture, what's currently happening, and clearly as demands and challenges change, and as new technologies come into play, you'll be in a position to tweak those plans as things progress. Yeah.
Brilliant. Well, you've already answered the last question that I had. So thank you for that, Brian. I know we've got about 15 minutes sort of left. I found it very interesting. It's always useful to understand it from a perspective of someone who's going into trusts and seeing the different services. But if I may, and as I say, I cannot see anyone. It's really about the opportunity for people to ask any audience questions that they have. And whilst people may put their hands up and we'll welcome all questions, here's some of the questions that we got prior to this, that if we can sort of briefly cover off, if that's okay, Brian. And then Chris, if you can hear me, let me know if there's any hands up, and sort of keep a note of whose hands go up first, so we can go around people in order. So just on this, there was a couple of questions. I'll sort of briefly summarize them. So how far in advance do other colleagues plan their workforce? So I'm assuming in other trusts, from your experience, when do people need to start?
Well, start now. I mean, it's an annual process for me. It should form part of the annual business planning cycle. I think the preparatory work around this should probably start in, I don't know, month 8 or 9. So October, November, in advance of the following April. Yeah. And
what about in terms of how far in advance should trust strategically plan in terms of years? It says anything in excess of 5 years. Do trusts do that? Should they do that?
I think some trusts may do it. They need to do it. I've not seen it, but I've not worked with everybody, so I'm not familiar with what's going on across the whole of the NHS. But those that I have worked with, they're not even really planning very well for next year.
Right.
I think longer term planning is probably almost non-existent. There's lots of demographic data, trend data available, to support, a 3 or 5 year view. But I think a solid 12-month view would be a good start, and then I think you build on it over time would probably be.
Absolutely, build up from a good position. Maybe not try to. What's the expression? Don't run before you can walk. Let's get that bit right. And then the final question, it's quite a long one, so I'll read it out.
Right.
how as a trust do we fit into the overall scheme of workforce planning? For example, we may need to increase consultant numbers locally, but there may not be the numbers coming through the training route. Does it need to be more regionally led?
ICSs, ICBs need to take a lead role in this. Absolutely. I think, you know, if you're looking at the sort of the population need across a patch for, you know, for healthcare, you shouldn't be looking at what's going on in, you know, where I live in Manchester, looking at what, you know, South Manchester hospitals need to do, what Central, North, Salford, you know. I think it needs to be, the ICS needs to look at the full picture, and there needs to be sort of flexibility of delivery across all of the providers. So yeah, I think ICSs need to take a lead role in it, working with acute and primary care partners. I think they're planning to do this in any case, but I think the planning's still in its infancy.
Mm-hmm.
I think if all of the trusts effectively workforce plan, I think it feeds into local decisions at ICS level. It sort of demonstrates to the commissioners what we need. This in turn, I think, probably feeds into sort of national discussions at, you know, the Department of Health and Social Care. You know, I think if collectively, if through the ICS trusts have got a handle on it, it's going to be it's going to be quite powerful. I think the data that comes out of it. I think in terms of consultant numbers, was it a bit about? Yeah, they need more consultants, but they're not enough coming and got off the training route. Well, just one, be sure that it's a consultant that you actually need. It could be a specialist grade, specialty doctor, clinical nurse specialist, actually, that could cover off some of the work, and they're cheaper and could be as effective with certain patients. I think a broader national approach to workforce planning with a 5-year sort of position clearly will influence education and training commissioning, but it'll take time to deliver, you know, for it to really come to fruition. I don't think it's a quick fix, but, you know, if we don't start the journey now, you know, the current pressures we've got are just going to get worse. I think it's interesting. I think medical workforce planners at a national level, I think they just didn't foresee that junior doctors were going to be dropping out and leaving the service, or the consultants would retire early, and I think that makes it difficult to react and resolve it in the short term. I'm probably rambling on, but I think gaps in rotas are not new. I think personally, I think we need to increase medical school places, so that maybe in 5 years' time, all of the junior doctors training schemes are filled. We'll reduce demand on bank and agency. We provide the future GP and consultant workforce. It might actually lead to competitive recruitment for senior roles, you know, where supply outstrips demand. So
this is the dream.
So, you know, I think, you know, I've seen lots of situations where there's only one applicant, and basically we recruit a pair of hands who may not be ideal, you know. And I think if it's more competitive, you know, that's got to be better for quality and for the outcomes for patients. But,
which again is the most important part. Okay, we've got a few minutes left, and obviously, I you know, if there's any questions that fall outside of this about some of the stuff I talked about at the beginning, I'm happy to hang around. But I hear Joe's got his hand up.
As somebody who was not so long ago a medical director, you know, responsible for the job planning of a couple of hundred consultants, I used to hate job planning because it was an awkward conversation about demand, and frankly, I was frightened to go into the sort of detail that was required. What's the offer from SARD to an overworked, busy medical director or HR director around what we could actually do to make it meaningful?
I'll take that one, Joe. I mean, I think what we found is that the system that Brian has sort of helped us build over the last year is essentially a game changer in terms of how it deals with bringing in the demand model and then reviewing that against your capacity model and delivering these sort of gap analysis and the ability to do sort of service redesign potentially with the resource that you've got. But that's not really the issue that trusts face. The issue is that they actually don't have the capacity themselves to do that, to engage in the process in the first place before they can have those conversations that they're slightly nervous about. So our offer at the moment is essentially to come in and work with a trust, sort of service by service, do as much of the heavy lifting as we can, because this is an output game. You know, selling the best input system, you know, is pointless if no one has the time to engage in it, or if no one can actually utilize or get the fruits of their labor out of it because they don't have the capacity to do it. So the whole point of what we're trying to transition to is to say, how do we actually get you to the output, accelerate you to the output, and then leave you in a position where years 2, 3, 4, 5, whatever onwards, you're in a position to do it yourselves without the immensely hard slog of the first sort of time of getting to. There's a reason why a little logo for this is a mountain. It's essentially, we accelerate the trust up to the top of the mountain, give you all the skills to stay there, so you're not reliant on us, but you have got an accelerated pathway through. Hopefully does that answer your question, Joe?
It does. It's just, you know, any medical director is going to be worried about committing to an eternal overhead, while at the same time they haven't got the time to get their nose up from the grindstone to actually do job planning properly. So what you're saying is you can come in, use the tool, you can match workload to actual job planning, and then leave a trust with the skills required to run it more or less themselves, yeah?
Yeah, for us, I won't go into specifics, but essentially the accelerator costs X amount. The what we leave you with costs about 10% of that. So it's the value of the work that is put in the first instance to try and help trusts get to where they need to be, and then any recurring cost is kept to a minimum to make sure that it's not a burden, but you are in a position. I think, as Brian mentioned, you is getting to that first point that is the most difficult part. Once you're there, actually it becomes relatively easier to do year on year, or build sort of 3-year team job plan, and then do your individual rounds each year. So that is essentially what we're looking to do. Our service is not an outsourcing service. I'm not talking about going in and doing it trust by trust, year by year. Absolutely not. That's not.
You have a hand up from Steve Bickle as well. Steve?
Hi, Steve. Yeah.
Hi, everyone. Yeah, thanks for that. It's really helpful. Just picking up a bit on what Joe said. I mean, you know, like a lot of trusts, we're financially, you know, in difficulties at the moment. And so there is a big issue about us trying to persuade the divisions and the execs that we do need to, you know, speculate to some extent in order to change things around. I'm hoping that, you know, for our trust in particular, but I'm sure it's the case for everywhere, the goal of improving productivity, for want of a better word. I don't know if you've got a better phrase for that, then that would be really good. But you know, we're a trust who've looked at our pre-COVID activity, compared it to now, seen that it's gone down, obviously, and it's not recovered. But in the meantime, our workforce has increased. I mean, that's really stark. It's not just clinical work, you know, it's not just doctors, it's nursing staff as well. So it's a no-brainer, you know, if we're less productive than we were pre-COVID with, you know, with more members of staff, then clearly we could be achieving a hell of a lot more with the staff we've got, potentially even with fewer members of staff. So not wishing to, you know, I don't think anyone's going to be making anyone redundant, quite frankly, because I think everyone's got staff shortages. We've just got the wrong people in the wrong places doing the wrong activity for our patients. And the thing that will really move things forward for us is to you know, realign that in a way that helps us to, you know, make sure that we've got the right people in the right place at the right time. And also, you know, as Brian touched on, just using better technology as well, and better uses of people's skills. We have too many consultants doing activity that could be done by other members of staff and not concentrating on the highly skilled areas that they should be concentrating on. So I'm not sure what my question was there. It was more about what you can do about it.
I think the productivity question is good. I think it's how you best use your resources. It's how productive are your resources as opposed to how hard they work in a role. Because it's about, as Brian said, just previously, do you need a consultant? Do you need someone to undertake a task that maybe somebody else could undertake? So it's how you best utilize that resource that you do have. And if there's way to make savings through new technology and so on, it shouldn't be as much about replacing people. It should be about ensuring that your resource is utilized in the right way. I think the money side of things is always a big query, but there's a massive expense for doing nothing around in this arena, or not investing in it, because it's not a problem that's going away. In fact, it's one that's widening in terms of backlogs and recruitment issues. So I think the value to sort of cost ratio, it needs to be looked at through numerous lenses. One, patient outcome, of course, is the most important thing. Secondly, if you have a well-organized group of people, you will see potential savings in terms of contingency spend and various other things. So it's the aim is, although it can't be a guarantee, the aim is to make this sort of work really pay for itself. But until you push past that initial really difficult barrier of actually getting the work in place, then it is always going to feel like an uphill struggle. That a challenge that some trusts will continue to probably hope will go away, but probably won't. So I don't know, Brian, if you want to add anything to that?
No, I think you've covered it. I was going to say, I think we carry on regardless. Then, your contingent bill is going to exponentially increase, and actually, it's huge. I should imagine in your organisation, it is in many, and really, you just need to sort of reinvest some of that into doing workforce planning properly, and. So we stopped feeding the agency beast, which is huge. They're making significant amounts of money out of the service. We need to try and cut it off at some point, or at least reduce it back to the levels that they were at, 20 years ago.
I hope that people found that conversation useful, and I'd like to thank Brian for your time and allowing me to pick your brains for almost the last hour. It's been really interesting and useful, and I know there's no doubt that you and I will continue to have these conversations about how we can potentially help improve things. But beyond that, thank you everyone. There will be a video recording available, which we've recorded it, so those who couldn't attend we can send it to, but if you feel it's of use to anyone else, then let us know and we'll send the recording out. But beyond that, thank you everyone for your time, and we look forward to seeing some of you at our next webinar, which we'll announce in due course.